Hi everyone, this is Becca Hunt from the Children's Safety Network. Welcome and thank you for joining us for today's webinar, The Role of Pediatricians in Screening for and Preventing Bullying. This is the final installment in a series of webinars on the issue of bullying awareness, response, and prevention that CSN is hosting. The series is based on the Building Capacity to Reduce Bullying and its Impact on Youth Across the Lifecourse workshop, which was convened by the Institute of Medicine and the National Research Council in April of 2014. This webinar series is produced in conjunction with the Health Resources Services Administration and also features a series of blogs that will appear on the stopbullying.gov website. To read the blogs, please visit www.stopbullying.gov/blog. And to see the other webinars, please visit thechildrensafetynetwork.org. To get things started, I'd like to pass it over to my colleague Rebecca Wilmer, who will talk about today's technology.
Thanks, Becca. So there are two options here today's audio. You can either listen through your computer speakers or you can call into our phone lines at 866-835-7973. Again, that's 866-835-7973. If you're participating via phone, please mute your computer speakers to eliminate echo. Phone lines will be muted during the presentations to eliminate any background noise. If you have any questions or technical issues at any time, you can type them into that Q&A box on the left. After the presentation, we'll pause for the presenters to answer your questions. We have two poll questions during today's webinar, and those will appear on the left side of the screen during the presentation. Please answer the poll questions when they appear. We also have several links in the link pod above the Q&A. So to view a web page, you can either click on its name and then select the Browse To button, and the resource will open in a browser window. Also, a PDF of the slides is available in this link pod as well. You may have to scroll down in the link pod to see it. This webinar will be recorded and archived and sent out to all registrants after the session. Back to you, Becca.
Thank you very much, Rebecca. So today we have two esteemed presenters, the first of which is Dr. Joseph Wright, who is the newly appointed professor and chairman of pediatrics at the Howard University College of Medicine in Washington, D.C. He most recently served as senior vice president for the community affairs at Children's National Medical Center, where he provided strategic leadership for the organization's advocacy mission, public policy positions, and community partnership initiatives. Dr. Wright is among the original cohort of board-certified pediatric emergency physicians in the United States with scholarly interests that include pre-hospital pediatrics, youth violence prevention, and the needs of underserved communities. He served 17 years as the inaugural state pediatric medical director within the renowned Maryland Institute for Emergency Medical Services System, and 8 years as principal investigator of the federally funded Emergency Medical Services for Children National Resource Center. Our second presenter, Dr. Matthew Masiello, serves as the Chief Medical Officer and Medical Director of Care Coordination for Children with Complex Medical Conditions at the Children's Institute of Pittsburgh, as well as Director of the Center for Health Promotion and Disease Prevention at the Windber Research Institute in Windber, Pennsylvania. His team of public health and education professionals are now commenting on their successful 6-year Highmark Foundation-funded initiative in implementing, monitoring, and evaluating the largest bullying prevention initiative in the U.S. Dr. Masiello is co-editor of the Public Health Approach to Bullying Prevention, published by the American Public Health Association. So with that, I'd like to pass it over to Dr. Wright.
Thank you, Becca, and thank you for the opportunity to participate in this afternoon's webinar. And I have nothing to disclose. And before we get started into the content of my portion of the presentation, I'd like to put out a polling question for the audience that should be projected on the screen right now that asks about the definition of bullying, and says the definition of bullying behavior includes all of the following except A, imbalance of power, B, intimate partner relationship, C, repetition, or D, intentionality. Again, the definition of bullying behavior includes all of the following except. So I will allow just a few seconds to see where the polling takes us and then move right into the meat of the presentation. Okay, I can see that the polling question is overwhelmingly providing us with the correct answer, which is B. The definition of bullying behavior includes all of the following features except intimate partner relationship. And let me go right on ahead into what that definition states. This is actually a fairly recently revised definition that was part of the Federal Partners on Bullying Prevention work, specifically out of the National Center for Injury Prevention and Control at the CDC. This definition was published a little over a year ago, and you can see there that it really speaks to youth experience of unwanted aggressive behavior by another youth or group of youths outside of a sibling or dating relationship that has occurred multiple times, has a high likelihood of being repeated, and is characterized by real or perceived power imbalance favoring the perpetrator. So when we talk about the characterizing features of this definition, it's important to recognize that repetition over time or the risk of repeated behavior, this is an important feature that we can discuss a little further. This is also behavior that is intentional, intent to cause harm, and is characterized by an imbalance of power. And when we think about the way in which bullying behavior is manifest in children, it breaks out typically into two distinct forms, indirect or direct. And there on your slide you see the types of activities or behaviors that characterize direct bullying, which is really in the realm of fighting behavior, pushing, slapping, punching, spitting, tripping, or indirect, which is also referred to as relational forms, characterized by behavior such as threats, teasing, rumor mongering, extortion, or ostracism. And these behaviors typically divide out by gender, but there's a great deal of overlap. Boys are more involved in direct forms, girls in indirect forms, but again, I want to stress that there is a great deal of overlap. And when we look at the way in which children are involved in bullying behavior, on this slide, I want to point out that you see that 3 of the top 4 ways in which children bully one another are in the category of indirect or relational forms. So on the slide you see verbal abuse, exclusionary behavior, and rumor mongering among the top 4 there. And this is important to understand because indirect forms are much more insidious and much more difficult to detect. So when we talk about bullying as a phenomenon, it is common. Much of childhood bullying is actually carried out by typically developing young children who are learning to navigate their social environments. Bullying behavior among elementary school children is actually common enough to be considered a normal developmental phenomenon. And so the question becomes, so what's all the fuss? This is the question, a question that I am asked quite typically as I'm talking about this issue. The concern is that of, emerging concern is that of the association of bullying, particularly among young school-aged children, with the subsequent development of retaliatory assault behaviors and deleterious health consequences. And as recently as the early 2000s, the question of whether bullying is truly the tip of an intentional injury iceberg and whether the association of bullying with these kinds of more serious behaviors down the line really had not been explored. And in this editorial from the Journal of the American Medical Association in 2001, it asked the question and pointed out that there had been no studies at that time that examined the relationship of bullying and being bullied with the risk of more serious violence. And since that time, through the work of a group at the National Institute for Child Health and Human Development, there's been a great deal of work that has ferreted out the association of bullying with the kinds of more serious behaviors that we're concerned about. Tanya Nansel and her group published early on that bullying is associated with higher rates of weapon carriage, frequent fighting and injuries, which is in my environment as a pediatric emergency physician where my initial contact with the issue began to pique my own interest. The associations are stronger for bullies than targets, and bullying should not be considered normative, but a potential marker for more serious behaviors. And when we talk about behavioral health outcomes, there's been a great deal of work over the course of the last decade linking depression and suicidal ideation as a common outcome of victimization of being bullied. And the associations are stronger for indirect versus direct forms of bullying. And I want to stress this point because, as I mentioned earlier, indirect or relational forms of bullying tend to be manifest more by young girls. And so the associations with regard to behavioral health outcomes seem to have a gender predilection. And when we look at even direct bullying, we notice that direct bullying is significantly linked with depression and suicidal ideation in girls only. So again, the more insidious and difficult to detect forms of bullying behavior, which tend to skew towards girls, is what is more significantly associated with deleterious behavioral health outcomes. And then when we look at the long-term effects, and this is an international study that I wanted to point out to the audience here, when we look at longitudinal cohorts over time, and much of this work, by the way, has been done internationally because here in the United States we are just beginning to scratch the surface with regard to longitudinal cohort studies regarding outcomes in adulthood. But in this work, we see here that children who are bullied, I'm looking at the conclusions there for you, children who are bullied and those who are frequently bullied continue to be at risk for a wide range of negative outcomes, including poor social health and economic outcomes, nearly 4 decades after exposure. And this is the kind of relationship that is being realized around the world in a number of similar longitudinal cohort studies that also bears great concern. So the question is, what's a pediatrician to do? And what I'd like to do over the course of the remaining slides here is to just talk about some of the elements of a policy statement that was published by the American Academy of Pediatrics about 5 years ago, which really took a crack at realistically assessing what the role of the pediatrician is with regard to not only youth violence prevention, but specifically with regard to bullying behavior. On this slide, you just see the front sheet of that article. So in terms of the recommendations, when we talk about the role of the pediatrician, community education period is a huge area in which pediatricians need to be involved and need to be advocates for. There's a very steep learning curve that I think all of us as adults who are involved with young people need to be schooled up on, and certainly bullying awareness by those adults who are in regular contact with children, whether at school, in after-school settings, and parents and children as well, is something that pediatricians need to advocate strongly for. Further, pediatricians and health professions in general need to be messengers, and certainly there are opportunities through all forms of media, print, electronic, online, to do so. In my own community, just a few years back when it was recognized that there was nothing literally on the books that defined bullying behavior from a regulatory or legislative perspective. This editorial in the Washington Post was something that helped to push the issue forward and bring our local community here in Washington, D.C. in line with the rest of the country with at least recognizing bullying from a regulatory standpoint. This is also a map that produced by the federal partners in bullying prevention a couple of years back that looked at the presence of anti-bullying professional development as part of the ongoing education of educators. And so if you look at the red states there, and red not as in political red, but red meaning states that do not have bullying education built into their teacher professional development, this represents an opportunity for healthcare professionals in a way that really does not have an economic note attached to it to be involved in professional development and education for teachers. And I mentioned that this is something that is not costly because certainly one of the first questions that is asked when there is any requirement suggested is, what's the fiscal note? Well, this is an activity that does not involve a heavy fiscal note at all and really just involves the incorporation, cooperation of those in the health professions and those in the education field. When we talk about schools, which is where children are most of the day, these endeavors, educational endeavors to engage school personnel are critically important, and it's critically important to provide evidence-based findings for school personnel so that the interventions that are applied and the kind of work that my colleague, who you'll hear from in a moment, are leading is as well understood in the school setting. The ultimate goal has to be to change school culture such that bullying behavior is not tolerated anywhere on the property. In terms of clinical practice, the challenge here is to incorporate yet another element of longitudinal care into the busy pediatric office practice. And what the policy statement recommends is utilizing a tool that was developed by the American Academy of Pediatrics as a primary care violence prevention protocol called Connected Kids. And Connected Kids incorporates mechanisms in which to screen, counsel, and provide appropriate and timely treatment and referral for violence-related problems that include bullying, and to do it in a way that is part of ongoing anticipatory guidance. And here you simply see some of the suggestions around open-ended questioning that allows a practitioner to be able to engage school-age children as participants in learning how to communicate and avoid or react to conflict that they may be experiencing in the school setting. And this is just an example of some of the specific guidance that the Connected Kids curriculum offers. And this is, again, the intent is to have this intervention be baked into an anticipatory guidance, asset-based approach that focuses on resilience. And you see here the 4 building blocks of anticipatory guidance that are part of the Bright Futures approach to longitudinal care that the American Academy of Pediatrics teaches all of us as part of our role in primary care pediatrics. And I want to, before I close, also reference that there is promise in anticipatory guidance. And one of the most sobering pieces of pushback that I often receive in talking to office-based pediatricians is how am I going to incorporate this into my already busy and crowded office-based experience, and finally, what good is it going to do? Well, our colleagues from the Harborview Injury Prevention Center have looked at, in a longitudinal fashion, the impact of simple pro-social activities, early cognitive development, emotional support, and responsible screen time, specifically TV watching, as predictors of subsequent bullying behavior, and found that parental cognitive stimulation and emotional support are independently and significantly protective against bullying, and not only bullying behavior as a victim, but also as a perpetrator. And also there appears to be a dose-related response with regard to screen time associated with the onset of subsequent bullying behavior in children who are followed preschool on into early elementary. Lastly, there is, and I am remiss to not mention the work of Susan Limber, who is the leading of Clemson University and who has been referenced on several of my slides as the leading researcher in the area, and who is working to develop a national data set, and in fact a surveillance system, if you will, around bullying behavior. And certainly pediatricians have a role to play in terms of contributing to the development of such systems. So the bottom line here is that adults and all of us as healthcare providers and in whatever domain we interact with young people cannot be indifferent to this issue. And I mention this because many of us grew up with a very different lens on the issue of bullying, and we must really acknowledge what the evidence is saying and teach our young people to not tolerate this coercive and abusive behavior. And lastly, attention to bullying cannot be separated from a comprehensive approach to youth violence prevention. So as was mentioned at the outset, I just want to make sure that all in the audience are aware of this workshop summary that was published last spring by the Institute of Medicine on the outcome of a two-day workshop on building capacity to reduce bullying. So with that, I will pass it along to my colleague and look forward to any questions during the discussion phase of the webinar. Thank you.
Thank you very much, Dr. Wright. And we will field questions. We should have about 15 minutes for questions for both of our presenters at the end of the webinar today. So now I'll pass it over to presenter Dr. Matt Masiello. And Dr. Masiello, you may be on mute.
I am off mute now, so it looks good.
Sounds great.
And here we go. Okay, well, thank you, everyone, and thank you, Rebecca, and Dr. Wright, as always, an excellent review of the role of the pediatrician. And I hope to spend the next few minutes talking about the challenges to the pediatrician. But I would like to have a poll question, and the poll question, let me see if it's where we want it. Okay. There we go. Okay. The poll question is to your left. Has your professional educational process over the years allowed you adequate exposure to learning and discussion and having discussion on the issue of bullying and peer victimization? I'll give you all a few minutes to respond to that. And as you're responding to that question, take your time, please. You know, interesting. Certainly, this is the gist of what I wanted to talk about today regarding the challenges to physicians. So the audience, I'm sure today is not all healthcare providers. I'm sure we have educators and social workers in the audience as well. So there's an indication here that whatever educational experience we have been exposed to, whether that is a social worker, an educator, a physician, we may not be getting all of the right information. As it relates to our task of today and the first point there, we're going to spend some time talking about the challenges and recommendations facing the physician. Sometimes the recommendations are challenges onto themselves. How can a physician or healthcare provider work with the various stakeholders and not feel that the entire burden of responsibility to address the issue of bullying is on his or her shoulders in an office setting? And I hope to review today the benefit of having available to the physician office-based and school-based tools that physicians can use and leverage to support and advise children and families who are exposed to bullying and related health consequences. So I make the challenge that physicians have somewhat analogous to teachers, in that as I've had the opportunity to go into schools over the past number of years, it's often a burden for teachers to take on new mandates already in a scenario where they are, to some degree, in many instances, burdened with presenting the children the educational curriculum and other activities, and now, lo and behold, comes another program, and another program that is not necessarily funded, and we call those unfunded mandates. Similarly, the pediatrician is in a similar position, where there are recommendations of what a pediatrician should be doing in his or her own office and in the community, but the situation in healthcare where it is now does not often provide that pediatrician, that healthcare provider, with the time or reimbursement to participate in that level of guidance and counseling. And we now know more than ever, and certainly more so than we did 10, 15 years ago when we first started talking about bullying in force here in the United States, that there are significant consequences to bullying in the day-to-day life of a child. And on the left, you could see the ramifications of the consequences of bullying in the population of children who are bullied as compared to the column on the right to children who are not bullied. And it's significant, especially if you go down to the bottom of that PowerPoint slide and see the relationship of bullying and the significance of bullying as it relates to the mental health of a child. So more than ever, it's incumbent upon the pediatrician not only to appreciate the overriding definition of bullying, but how the consequences of bullying impact their practice. And as Dr. Wright alluded to earlier, we are now in a much better position than we were years ago, where years ago we looked at bullying as a phenomenon relating to the child and to whether it be middle school or high school. Now we're seeing more studies talking or demonstrating to us the consequences of bullying. And I'd like to review this with you. Dr. Wright touched upon it in his presentation, but I think it's important that as educators or healthcare providers, we really have a grasp of the consequences of bullying beyond the school-age child. Groups involved in bullying of any type in adolescence had an increased risk for lower education as young adults compared to those non-involved in bullying. As adults, the bullying group in this particular study had a higher risk of unemployment and receiving social support. Those bullied and bully victims had increased risk of poor general health and high levels of pain. Bully victims and those aggressive towards others during adolescence had increased risk of tobacco use and lower job function, as well as increased risk of illegal drug use. The study goes on to tell us that relationships to live-in spouse and partner were poorer among those being bullied, and involvement in bullying either as a victim or perpetrator had significant social costs even 12 years after the bullying experience. So significant. So there are plenty of recommendations now available to physicians and healthcare providers of what to do, but what are the challenges? And the challenges, and not as well documented as we would like to see at this point, are how we as healthcare providers are trained in this arena of bullying prevention, and the biological and psychosocial consequences of bullying and peer victimization. We're doing better, but we really don't get that information in our medical schools, in our residencies, and even in our certification process as physicians, there is very little in the educational material provided to physicians to educate them on the issues relating to bullying, and thus we are not necessarily tested as community-based physicians on those issues. So there's a gap, there's a fragmented area of education as it relates to what we as physicians should know. We are at a period in our healthcare reform process where physicians, and it's not a secret to any, especially those of you who present in a physician's office and realize that the physician is more limited with his or her time than ever before. There's a minimal amount of time that the physician has available to the parent to get all of the information that we are now asked to do, that our society, that our professional societies and other groups ask us to offer to the patient. And more so than ever, the time we spent, and we do spend with our patients, needs to have some reimbursement quota to that. And at the moment, there is very little out there that allows managed care organizations and payers to reimburse the hospital, the clinical practice, the physician group for the time they spend with a parent on these issues relating to bullying and peer victimization. So what can we do? We feel, and the feeling out there now amongst so-called public health experts is that it's a public health approach. And when we deal as public health professionals and public health researchers in a community and trying to go out to the community and ask what the issues are, we ask very basic questions: who, what, when, where, and how. And this can be the very basic approach that a physician can have in his or her own office. Just ask these questions as it relates to bullying, and you will be absolutely surprised. And the reports and the data that's come back to us really has been tells us that it's been an eye-opening experience for the pediatrician when they at least start the discussion. And it doesn't have to be a lengthy discussion, but just start the discussion on bullying. That immediately makes the connection between the family and the practitioner, between the child, whether it be a middle school age child or an adolescent, and the physician, in that they are at least interested in dealing with the issue. Let me give you a brief rundown of what we were able to do in Pennsylvania in our 49 counties from 2007 to about 2014-15. We were able to impact with an evidence-based bullying prevention program over 200,000 children, over 400 schools, about 17,000 teachers, and approximately 350,000 parents. And we were able to affect the typical community, rural, town, suburban, and urban areas in those counties that we had the opportunity to reach out to. And what we were able to do in a 6 to 8 year period of time is demonstrate a significant decrease in student self-reports of being bullied, significant decrease in students' reports of bullying others, significant increases with regard to students' perceptions that teachers and other adults help to stop bullying. And we also saw that students were less willing to join in bullying and more likely to try to help a bullied student. We had the opportunity to present this information to national organizations at the, I think this was the 2014 gathering of the American Public Health Association. And we very deliberately went down a path to get this information out in very specific areas. As you could see from that first print or a peer review article, we wanted other individuals, other healthcare providers, other experts in bullying to see what a foundation can do to gather stakeholders to form coalitions to address this issue of bullying. We also wanted to demonstrate the importance of foundations in our country in stepping up, and the Highmark Foundation in Pittsburgh was nice enough to do that and sponsor this multi-million-dollar, multi-year, large population initiative on bullying prevention. One of the criticisms that we have had in bullying prevention work is our inability to demonstrate a cost-benefit, and in this large population, long-term bullying prevention initiative, we've been able to begin the comment on that particular initiative. And this work, interestingly enough, came about when pediatricians in the community approached school nurses and asked what their top 3 issues were, and this was around 2000. And one of the top 3 issues of the school nurses in southwestern Cambria County was bullying. And this is where this study all began. We're now getting down to the office practice, and we have a study in place now where we're looking at what is happening in a physician's office, what a physician can do in working with families. We're developing a decision tree which frames questions providers can ask their patients based on their level of involvement in school-based bullying, whether it's a bully, target, or bystander. And it also recommends very specifically some level of guidance for providers to pass along to patients and their families, as well as suggested plans for follow-up interventions. We were able to put all of this together in the public health approach to bullying prevention that we had the opportunity through the American Public Health Association to publish and make available. And this is a document that, along with other documents from other folks, have commented on the importance of looking at this issue as a public health issue. So what can we do as physicians, realizing that there's a significant challenge, and the significant challenge that we have before us are the following. 1, the time we have in the office. 2, reimbursement. 3, the knowledge we have on the issue that is still not there in our medical schools and our residency programs and our continuing medical education processes. But what can we do to at least begin the effort and become partners with others? We could ask the question. I know it sounds so simple, but just simply ask the question, who is bullying you? When is it happening? What exactly is happening to you when it does happen? And where does it happen, and how does it happen? Many of us pediatricians now are embedded in the medical home process level of activity. We should be doing our best to try to get bullying and bullying prevention into that process. Children with special needs, with complex medical conditions, are at a heightened risk of being victims of bullying. And pediatricians should use their time to seek out what evidence-based tools are coming down the pike to be available to them. It's difficult these days for a physician to get into a school to give that lecture on any given project, but there are happenings and activities in schools now that at least allow the physician to be a partner or partners in that effort. Schools are mandated to have some level of a health group or a health committee or a health council. The CDC has a very good program that really all schools should be committed to in developing their health council, and it's identified as the Coordinated School Health Council. It's very pertinent in this situation because there are some significant mental health and physical health issues related to bullying. If the school is able to have a council health committee in place to address the mental health and general health issues of the population in that school, it's going to be a natural pathway into also dealing with bullying as it relates to those mental health issues and general health issues, when this type of coordinated effort to organize the school around a health committee is available to the teacher. Schools really now are being asked to, and I think they understand, but again, it's often a matter of finance and having the ability to pay for these programs, but we should be trying our best in our schools to have evidence-based programs available to our children. And when you are able to, make yourself available to the schools, and especially to those programs, and identify, whether it be at the national level, state level, or regional level, identify those experts in your area that could provide certain information to you. And very importantly, we need to help our media get across to the public when these bullying type events or violent events related to bullying come up, and we need a spokesperson to try to identify clearly the issues related to that event. Oftentimes the media has a well-intended but somewhat fragmented and often not necessarily always on the mark approach to clearly identifying whether this incident that they're trying to report on is a bullying incident or just a random act of violence. And in our professional organizations, we need to push hard as pediatricians and nurses and family medicine physicians to getting our organizations really up to date, up to snuff on what we as healthcare providers should be learning and what we should be endorsing and the research behind all of this and getting the word out to our colleagues as well as to our communities. I've made available here some resources that I feel have been helpful to the pediatricians working in Pennsylvania, and certainly at the top of the list it's the stopbullying.gov. Recommendations coming from the professional organizations are very important. The 2009 recommendation on the role of the pediatrician in youth violence is important, but even that needs to be updated to be more inclusive or more expansive, let me put it that way, on the issue of bullying. You could have a violent act and it's not necessarily bullying, and bullying is not always necessarily violent. So we need to, yes, include bullying in this conversation of violence, but it needs to have a broader base now level of conversation in our professional organizations. The American College of Pediatricians comments that bullying in schools should never be acceptable, but in their statement they introduce a rather controversial statement, and that we need to be clear, and we need to be able to explain these statements when larger organizations are in a position to comment on what bullying is or where we should be going. Students attending schools with bullying prevention programs were more likely to have experienced peer victimization compared to those attending schools without bullying prevention programs. Well, yes, to some degree, but not really yes to a significant degree when bullying prevention programs are presented with the highest level of fidelity and with the appropriate level of evaluation. So when our organization present this type of information, thus a challenge to pediatricians, we need to be able to explain more completely the nuances behind these types of statements. Clearly, the Children's Safety Network is on the mark for bringing this information forth. The foundation and organizations such as Safe Schools in Pennsylvania and the Highmark Foundation, and special recognition to our Dr. Wright, who has really taken the lead at the national level for moving ahead this topic of bullying and bullying prevention. And the nurses, to some degree, are taking are a few steps ahead now, I would say, of where pediatricians should be in getting the message across. Their updated position letter on bullying prevention, on bullying in schools, is a bit newer and more complete than what we have now as compared to what's coming out of our pediatric society. So we need to do better with that. As coming to a close, here is a nice tool that was developed by the Center for Safe Schools in Pennsylvania, funded by the Highmark Foundation, and it is a toolkit that we are using in some of our practices now as we are developing and designing this office-based study to help practitioners serve as better advocates of bullying prevention. And what came out of the workshop in the Institute of Medicine is a committee now on the biological, to study and comment on the biological and psychosocial effects of peer victimization for bullying and bullying prevention. So that information and that statement will be available to us in 2017. So as you could see, there's a significant amount of activity and research going on at this time. We need to do our best to not only offer recommendations to our healthcare providers or pediatricians, but find out and give them the tools and resources to be in a position to get those recommendations across to the patients and populations they serve. And I thank you very much.
Thank you very much, Dr. Masiello and Dr. Wright, for those presentations. It's wonderful to hear from you and hear that there are so many resources and opportunities to get engaged with bullying prevention and work with the community. I would like to invite our audience members to start submitting questions. You can see the question and answer pod on the lower left-hand side of your screen. If you type in a question there and send it over to us, I will read it out loud and make sure we address as many questions as we can in the next 15 or so minutes. So we do have one comment from the audience saying regarding the data you presented on in schools with bullying prevention programs, victimization actually goes up. So the audience member just wanted to say that often bullying prevention programs result in higher reporting of victimization and bullying because of the students' awareness of the issue. Reporting often goes up before it goes down. So that's just one quick comment. And for other questions, we have several audience members who are asking things specific to age. So is there a specific age physicians should focus on for bullying screening? Is there an age where it picks up more, or is it really across the adolescent and child lifespan?
This is Joe Wright. That's an excellent question, and I will share that we have in the American Academy of Pediatrics have sort of ratcheted the attention and approach to middle childhood. However, I think it's pretty clear that certainly the rudiments of bullying behavior start much earlier. And the work of our colleagues out at the Harborview Injury Prevention Center, as well as the work of, which I didn't mention, the Sesame Street workshop, have targeted primary prevention as their goal, in recognizing that these behaviors are present and recognizable in preschool children. So I think the simple answer to the question is that while the recognition and the overt manifestation of bullying behavior is something that is recognized in elementary and middle school age children, it is pretty clear that the rudiments, if not the overt manifestations of the behavior, are present and recognizable in much younger children.
And if I could add to that, where the research is taking us, especially with our psych colleagues, is now taking us closer and closer to this issue of empathy. The more we can instill in our young children this virtue of empathy, and practice that at home before the child is in school and as they enter the early school years, that is going to have an impact in many ways, but also in our ability to appreciate children who are different and our friends who are different. So this topic of empathy is now being studied at a much more active rate and at a higher level. And I think we're going to see more and more that, yes, the emphasis is on trying to recognize these bullying behaviors earlier on, especially in the middle school years, but really the effort needs to begin much earlier than that, so we could get to a point where we don't have to recognize or be in a position these bullying behaviors in middle school, that early intervention is going to be the best approach.
Great. Thank you very much to both of you for that response. One of our audience members is asking about training of residents and medical students on the issue of bullying, screening, and prevention. Are there currently any training efforts for residents and medical students?
Well, I have had, this is Joe Wright. I have taken a look at, for residents, at the Residency Review Committee's ACGME, Accreditation Council on Graduate Medical Education, language for pediatric residency programs. And while the term bullying is not explicitly referred to. There are certainly areas within the ACGME RRC guidelines that allow for insertion, if you will, education on this issue. The ACGME RRC guidelines tend purposely not to be overly prescriptive with the way in which programs the way residency programs develop their curriculum. But at the same time, to Dr. Masiello's point, it's critically important that the voices of experts who are responsible for training of the next generation of healthcare providers work to incorporate the kind of content that we're talking about today into training curriculum. I think it's even less incorporated into undergraduate medical education curriculum. So we have a ways to go in terms of climbing this learning curve around the issue, but I think that there are opportunities, particularly with regard to any specialties, ACGME, RRC requirements.
There is another factor here. If we train our physicians, if we get to that point where we're appropriately training our medical students and residents and physicians on the subject, we have to be able, as physicians, pediatricians especially, to get out to the community. That's becoming more and more of a challenge. There was a recent article out of Pediatrics by Minkovitz in 2014 in their survey, in her survey, really commenting on the fact, unfortunately, that pediatricians are being seen less and less often out in the community, that they are basically office-based now, and those physicians who are out in the community are basically those physicians doing some volunteer work or the older pediatricians, not the newer pediatricians who are coming out of their training. So that's another dilemma, another challenge that we face. How, once we give the pediatricians this education and we learn how to give it to them into the medical school or residency, how are we going to get them out into the community in some form or fashion to propagate this information to schools and other community groups?
Thank you. Excellent considerations to keep in mind. Another question from our audience members, which relates to some things we've learned on previous webinars in this series about the relationship between those who commit acts of bullying and those who are themselves bullied, and how those are really overlapping populations. So when physicians and pediatricians screen for bullying, do they screen for victimization or perpetration? And would there be a difference in referral or services that would be provided to that youth based on whether or not they were a victim or a bully?
I could jump into that, and I'll use if it's okay with you all, I could jump into that from the perspective of what we're trying to do in the physicians' offices now in this study. Yes, the child who is doing the bullying really represents a relatively small segment of the population of children who are involved in the overall act of bullying. The bystander is a significant actor in that effort, as well as the child who is being bullied and the child who is doing the bullying. And there are children who are actually doing both, who are bullying and also are victims. So we have to ask those questions, as I alluded to earlier. Just start asking the questions. And it could be simple. It could be as simple as, do you experience bullying? Are you being bullied? Are you the bully? And it's very interesting that children in the right setting will come up with a very honest answer. And the approach needs to be different. It does, and we need to give the pediatricians the tools to use to take that family down the path, the appropriate path of guidance and prevention, if their child is the bully, if their child is the bully victim, or if their child is the bystander. So yes, it's a much more intricate, complicated path now that we need to take our families down as compared to 10 or 15 years ago, where we're seeing that there's such an incredible interaction between all of these groups. It's just no longer just the bully and the victim. Thank you.
And just to and thank you, Matt. That's an incredibly important concept. And just to put a statistical framework around it, an epidemiologic framework around it, it's been estimated that by third grade, between third and sixth grade, fully 77% of children have been exposed to bullying, primarily through the bystander role. Somewhere under shy of 20% of children are involved as a bully or victim. The overwhelming majority of children are involved as a bystander, and some of the evidence is suggesting that in terms of intervention, in terms of risk and consequences, that the bully victim is actually the category of experience that is most at risk and most troubled. So it's a very important question that this is a pervasive issue that is not limited to the small category of children who are bullies or victims, but it needs to be targeted towards the entirety of the experience.
Excellent. Thank you so much. I think that's a wonderful point to carry home with us. We have time for one, possibly two more questions. And several of the audience members are mentioning the role of adults in bullying prevention as well as bullying, the cycle of bullying. So I was wondering if you have any comments about how physicians of adults could get involved either with screening for past incidences of bullying, screening for behaviors that could model poor bullying behavior for their youth, or helping parents who might have a child who is a victim or a bystander of bullying to know what to do in that role. And if you see a role for physicians of adults getting engaged in bullying prevention to help stop the cycle.
I'll just very quickly state my personal experience over the course of the last decade. It has been very clear to me that we are really at a watershed moment as a society on this issue. As I mentioned, certainly I did, and certainly many adults grew up with a very different lens on this, and have not had the kind of experiential exposure, even as health professionals, to really understand in a way that we're trying to communicate today about the importance of the issue. So I think it's really critically important that we all examine as adults what our own experience and our own views on it. It is not uncommon after we've made this kind of presentation for the health professionals in the room to stand up and offer their own lens on the experiences that they had as a child and how it impacts their views and their practice today. So it's really fascinating to me that I think we have an opportunity for, from a generational perspective, for the young people to lead the way. And in fact, in many ways, that is what's happening, and sort of leading the way for the adults as well. I think it's a critically important question that there is as much need to climb the learning curve for adults as for kids and families in this matter.
Well said, Dr. Wright.
Great. Okay. Unfortunately, that is about all the time that we have today. Clearly, we could ask many more questions and dive even more deeply into this topic, but I do encourage you to go and visit the resources that we mentioned today, talk to your own physicians and pediatricians about bullying, or get engaged in your own work if you are a physician or a pediatrician to help stop the cycle of bullying. There is a brief survey on the screen in front of you, an evaluation for today's webinar. If you could click on that link and fill that out, we would be very grateful. We're always looking to improve our work here at the Children's Safety Network. And with that, I'd like to thank our presenters one more time for joining us today and giving us a wonderful presentation and much food for thought. Thank you very much, and have a wonderful day.
Thank you.
Thank you.